Alright, welcome back everyone. Dr. Naveed here. So today we are covering the lower back. Now honestly, when I was a fresh graduate, these were the cases that confused me the most. Not because the diagnosis was rare, but because the things are not always what they seem. So I have got two cases for you. Let's see how you handle them. We're not gonna do any spoon feeding. You know the drill. I'll show you the case, you pause, you think, and then I'll walk you through my thought process. Not just the right answer, but what's going on in my head when I see a patient like this. The first case looks like a classic back problem, but is it really? The second one, a guy lifted something heavy and now he's got pain. Sounds simple, but there's one thing in the history that should set off every alarm in your head. Alright, let's jump in. Alright, case number 1. A 62-year-old woman presents with a 4-month history of deep pain in her right buttock that sometimes travels down the front of her thigh towards her knee. The pain is worse with walking and standing up from a low chair. When you ask her to point to the pain, she cups her hand over the side of her hip and groin, not the lower back. Straight leg raise is negative. Lumbar spine range of motion is full and does not reproduce her symptoms. What is the most likely source of her pain? Option A, lumbar disc herniation with radiculopathy. Option B, sacroiliac joint dysfunction. Option C, hip joint osteoarthritis. Option D, piriformis syndrome. Alright, pause here. Think about it. Where is she actually pointing? What tests are negative? Press play when you've got your answer. Alright, if you picked C, hip osteoarthritis, you are right. But honestly, in clinics, many new graduates pick A, the disc. Let me explain why that is wrong. Look, when you hear leg pain, you think disc. I get it, but here's the problem. Her SLR is negative. If there's a disc compressing a nerve, SLR is usually positive. Second, moving her spine didn't change the pain. If the spine was the problem, moving it should do something, right? And third, and this is the biggest one, she is pointing to the front groin, anterior thigh. Disc pain typically goes down the back or the side of the leg, not the front. That's a totally different nerve supply. SI joint, yeah, it can refer to the buttock, but SI joint pain is usually localized to the PSIS, that dimple area. This woman is pointing more anterior towards the groin and her pain is aggravated by walking and sit to stand. That's hip loading, not SIJ provocation. Piriformis, again buttock pain, yes. But piriformis pain is posterior, deep in the bum, and it's usually aggravated by sitting or by putting the hip into adduction and internal rotation. This woman's pain is anterior, groin and front of thigh. That doesn't match. So, why the hip? Here's what I learned early on. True hip joint pain, whether it's osteoarthritis or something else, is felt in the groin, not the buttock. Not the back, the groin. Sometimes it goes down the front of the thigh, even to the knee. That's because the hip joint shares nerve supply with the obturator nerve, so the brain gets confused about where the pain is coming from. And that thing she did with her hand, cupping over the side of the hip, we call that the C sign. Very common in hip osteoarthritis. It's not a test, it's just an observation, but in practice, it's surprisingly useful. So, when you're assessing someone with back and leg pain, check their hips, especially internal rotation. If that is stiff and painful and they've got groin pain, think about the hip joint. So, your takeaways: number 1. Groin pain is the hip until proven otherwise. Number 2. Always check the joint above and below. Number 3. Don't treat the spine if the problem is in the hip. Alright, that's case 1. A good reminder to look beyond the obvious. Now case 2. This one is different. It's not a clever differential. It's something that honestly scares every good physio. Because if you miss it, the consequences are not just pain, they are permanent. Case number 2. A 40-year-old man presents with acute low back pain that started 3 days ago after lifting heavy furniture. Today he tells you the pain is no longer just in his back, it's now spreading down both legs. He also feels a strange numbness in his inner thighs and groin. He mentions he is having difficulty passing urine since this morning. He feels his bladder is full but cannot empty it properly. What should you do next? Option A, start gentle mobilization and give McKenzie exercises. Option B, reassure him and review in a week. Option C, suspect cauda equina and send to emergency immediately. Option D, refer for routine MRI and continue physio. Pause, I'm serious. Think about what you would actually do if this man was in front of you right now. Press play when you're ready. Alright, the correct answer is C, cauda equina, emergency. If you didn't pick this, it's okay, but we need to talk about why the other options are dangerous. Mobilizations, Mackenzie? No, absolutely not. This man has bilateral leg symptoms, saddle numbness, and urinary retention. You do not touch his spine. You do not give him exercises. This is not a mechanical problem. This is a surgical one. Mobilizing him could make it worse. Reassure and review. Look, I know we want to make patients feel better, but telling him it's normal and sending him home is not reassurance. It's negligence. Bilateral leg pain plus urinary problems is never ever normal. If you send him home and his bladder never recovers, that's permanent. Routine MRI? He needs an MRI, yes, but not a routine one. Not next week. This is an emergency. He needs MRI today. The nerves of the cauda equina are extremely sensitive. If they stay compressed for too long, they may never recover. That means permanent bladder dysfunction, permanent numbness. You can't wait. So, cauda equina syndrome, what is it? Your spinal cord ends around L1. Below that, you have a bundle of nerves that looks like a horse tail. That's what cauda equina means. These nerves control your bladder, your bowel, your sensation down there. If a big disc squashes that bundle, you've got a surgical emergency. The red flags, remember them? Bilateral leg pain or numbness, saddle anesthesia, that is inner thighs, groin, and perineum, urinary retention or incontinence, bowel problems, progressive weakness in both legs. You don't need all of them. Even two is enough to act. So, what do? You stop the assessment, you don't do SLR, you don't check the lumbar range of motion, you pick up the phone and call the emergency department, tell them suspected cauda equina, bilateral leg pain, saddle numbness, urinary retention, and you send the patient right now. Don't let them drive, don't tell them to come back tomorrow. This is the one time in physio where time matters. So please always ask about bladder and bowel in your history. Always bilateral symptoms plus urinary changes in an emergency. Don't treat, don't delay, refer immediately. Alright, two cases. One reminded us that the hip can look exactly like the back. The other reminded us that some things are bigger than physio and our job is to recognize them. If this helped, drop a comment. Tell me, have you ever seen a hip get mistaken for sciatica or a close call with something serious? Hit subscribe if you haven't. Share this with your colleagues, especially the cauda equina stuff. It matters. I'm Dr. Naveed Ul Zafar. See you in the next one.